Okay, so to begin the discussion on neurological conditions, probably of all the conditions we're going to talk about, the one you will encounter the most, and I particularly want you to pay attention to a lot of the stuff in your textbook on the diagnosis and the testing of concussion. So make sure, when you go back after taking notes here, go back and kind of take a look at that section and really focus on some of that information. Because regardless how much you get tested on it here, you're going to learn more about it later on anyway in some of your other classes. So it's really relevant to what we do. So sport-related concussion, a complex pathophysiological process affecting the brain induced by traumatic biomechanical forces. The mechanism here is one of two things. It's either a direct blow to the head, face, or neck, or a blow elsewhere on the body where the force gets transmitted to the head. So it can be either a direct or indirect force. So aside from just getting, hit in the head or hit in the face, you can have this indirect, almost jarring somewhere else in the rest of the body that causes the brain to be traumatized. So we then, after this would happen, would have kind of our complex presentation of symptoms, which we're going to get into a little bit as far as what goes on with that on the next slide. So typically concussions result in a rapid onset of short-term impairments of neurological function. So an important thing to note, this is a functional disturbance. So structurally, when someone has a concussion, there's nothing actually structurally wrong with the brain. In other words, if someone only has a concussion, they go and get a CT scan done, you're not going to see anything on the CT scan. It's going to be negative. Because what's happening is it's kind of a cellular and chemical response that's really causing a lot of the signs and symptoms related to concussion. So, and it doesn't necessarily have to involve loss of consciousness. And as a matter of fact, sometimes loss of consciousness isn't even indicative as to how severe or how long the person's going to have symptoms for. So there's no abnormality on standard structural studies with concussion. And it's important to note that the resolution of the clinical and cognitive symptoms follow a kind of a sequential course over the time of the injury, but some post-concussive symptoms may linger a little bit longer. So really kind of take a look at what some of the signs and symptoms that you could experience are and kind of how they present throughout the course with a concussion. I think it's important to note things. So obviously, trauma to the head, face, very common in contact sports. Signs and symptoms if you have to refer immediately. So, and the reason why you would be referring is because of the fear of there being something beyond a concussion. So a concussion is a significant injury to the brain, but there's obviously things that with trauma to the head and neck that could be even more serious or have more, long-term consequences if not dealt with in a expedited manner, if you will. So any significant deterioration of neurological function, any decreasing level of consciousness. So you have an athlete, they're on the sideline, they've kind of been through an evaluation, now they kind of feel like they just want to go to sleep, or they're not, I guess for lack of a better way of putting it right now, staying with it. That would be an indication to refer them to the emergency department. Any seizures that would result as a result of head injury, any kind of changing with respirations or heart rate, unequal, unreactive, dilated pupils, signs and symptoms of any other associated injuries that are significant, or anything indicative of a skull fracture. So any of this stuff, if the person was assessed for a concussion and they seem like they deteriorate or develop any of these symptoms, would be indicated to refer them to an emergency department for further testing, just to make sure that there's not an even more significant injury present with this individual. Okay, stroke, or also what is known as a cerebrovascular accident. So this is caused by lack of oxygen to the brain. So basically what happens is due to either a blood clot or an aneurysm. So an aneurysm is any weakening in a blood vessel. So what basically happens with an aneurysm is that the blood vessel wall, for whatever reason, gets weak, and then it kind of pouches out and balloons, and then it could possibly rupture. So anytime there's lack of oxygen to the brain, you would have that. There's also your textbook talks about something called a transient ischemic attack, or a TIA. That's basically essentially what some people refer to as a mini stroke, and that's kind of like what they are is that there's a warning sign that the brain is not getting its full blood flow for whatever reason. So a pure stroke hasn't happened yet, but it's a warning sign that for some reason there's there's not optimal blood flow to the brain. So with a stroke, obviously because of lack of oxygen to the brain, there could be some neurological damage and possibly paralysis. Whether that's reversible or irreversible will kind of depend upon basically how quickly the person gets treated and the severity of the stroke. So there's some particular things as it relates to kind of stroke recognition. There's a very important mnemonic that your textbook talks about. Make sure you kind of highlight that. And again, because the faster the recognition for stroke, the better long-term outcomes the individual has. Now, again, strokes don't tend to happen in younger people, but they can. So it's important to be able to recognize that. Or if you're a medical professional working an event, maybe someone, many times this would be something you could see, maybe in a bystander in the audience that you would be administering, first aid to. So that would be important to be able to recognize this and get the person expedited treatment. Guillain-Barré Syndrome is an acute disorder where the myelin sheath gets basically destroyed. So it's a diffuse demyelinating disorder of the spinal roots and peripheral nerves. So if you remember when we were talking about the nerve cells at the beginning of the chapter, and we had mentioned that the axons with the myelin sheath, well, this is a disorder where that myelin gets destroyed. So it's an autoimmune syndrome. Many times it presents with very severe signs and symptoms, and it could progress very rapidly. And there's different reasons as to why this could possibly occur. One thought is that their specific lymphocytes produce antibodies against component of the myelin sheath. So with looking at that, just to review this, because I don't think we had talked about anything related to the autoimmune system yet. An autoimmune disorder is when the body's immune system attacks itself. Okay, so when you hear the term autoimmune, it basically means that we know we have our immune system, that when there's when you're sick, your immune system works. Why? Because that's a foreign thing to the body. Well, with an autoimmune disease, the immune system just becomes overly reactive to normal parts of the body. And that's what you have with Guillain-Barré. So really important to kind of note the progression of the signs and symptoms and some of the important clinical history to determine this, because this is something that, if it's caught early, can be treated fairly well and there could be some good outcomes. If this progresses, though, and gets missed, it is definitely something that could cause some long-term disabilities, or even possibly death. So it's something that can progress, and it can progress as far as basically ruining the individual's ability to breathe on their own. So really important to kind of note where this kind of comes from, where some of the precipitating events that could lead to it are, to recognize this early. Okay, headaches. Now, your textbook we'll spend a little time talking about headaches. So it's the most common disorder of the nervous system. There are a lot of causes of headaches. So really important to note all the different types of headaches. We're going to talk about some of the presentations of some of the different ones here. So to kind of differentiate, because then that could kind of help with treatment. Obviously, there are some headaches that have much more severe signs and symptoms than others. So vascular headaches are caused by spasms of the vessels around the brain. Probably two of the more debilitating types of vascular headaches are migraines and cluster headaches. So migraines in particular have certain things related to their presentation that are pretty relevant. But these are probably two of the more severe vascular headaches. So basically with a vascular headache, the blood vessels surrounding the brain go into various degrees of spasm and constriction and then cause dilation. You see this with migraines, where it kind of fluctuates between vasoconstriction, or the blood vessels kind of going into a really deep spasm, versus and then going into vasodilation. And both of those things kind of cause some of the varying symptoms as it relates to migraine headaches in particular. Again, other types of headaches, so tension headaches, again, a common thing, result from muscular tension on the cervical spine and cranium. So, if there's muscular tension for whatever reason, and, stress, postural issues, that can cause headache symptoms as well. There's traction and inflammatory headaches. So things like eye strain, hypoglycemia, or which is also known as low blood sugar, stroke, sinus infections. Again, what you want to look at here is how is it we know if someone comes to you and they have a headache, look at where they're having their headache, because that could sometimes clue you in. And then look at your other precipitating factors. So when you're looking at all these different headaches in the textbook, also look at what are the precipitating factors and what are some of the slightly different things that could come about as a result of, as far as signs and symptoms wise, for these different headaches. And here's just to show an example. So this is in your textbook, but it's kind of showing you kind of your location. So this would be kind of a thing that can help you differentiate, because again, there's many different types of headaches. There's more reasons even for cause for headaches than even what's in your textbook, but you have quite a few that get described. So you can see the differences in locations. So migraines, for instance, classically are unilateral, meaning they usually present just with one side, and it's usually pretty much a diffuse in the whole side of the face. Juxtapose that with a cluster headache. Many times cluster headaches just form around one eye. Okay, so you can see here, so one of the first things, describe your headache. What do you have? If someone has pain behind their forehead and cheekbones, it could just be related to inflammation of the sinuses, and then you'd have to find out, is it a bacterial sinus infection? Is it a viral? Have they had a cold recently? Those would be some things you would want to look at. So look at that, and then a couple of the other types of headaches that get discussed. Just again, kind of pay attention to some of those different clinical presentations. Okay, seizure disorder and epilepsy. Okay, so a seizure is an abnormal discharge of electrical activity in the brain. So the outward manifestation of this is a combination of things. It's a combination of altered awareness, so altered awareness as far as like what an individual's surroundings are, involuntary movements or convulsions. So again, seizures themselves could happen aside from epilepsy. So epilepsy is kind of the disorder or chronic condition where an individual kind of has like unprovoked random seizures, whereas someone can just have a seizure secondary to another problem. In other words, say for instance a brain injury or heat stroke or hypoglycemia, alcohol consumption, drug withdrawal. Those are all things that can cause a seizure. Epilepsy itself is the actual chronic condition that causes seizures. Now, some other things to kind of note, there are different types of seizures that an individual may suffer from. So that would be an important thing. If someone does say that they have epilepsy, it would be important to kind of note, do they have anything that kind of precipitates their seizures? Many times individuals that have seizures will say that they experience like an aura or kind of like a sensory manifestation right before they have a seizure. Most generalized seizures get classified as what's called tonic-clonic seizures, which are, kind of what we think about as far as the convulsions. So there's the tonic and the clonic phase related to the seizure. There's also what's called an absent seizure. So an absent seizure would be something where, the individual doesn't experience convulsions, but that's kind of, I'd mentioned the altered awareness. So many times the person, again, for lack of a better way of putting it, they kind of like space out a little bit, and then they all of a sudden just sort of snap out of it. That would be what we'd call an absent seizure, or what also would be called a petit mal seizure. So your textbook kind of talks about some of the differences as far as the different seizures are concerned. So pay attention to that when you're kind of looking at your signs and symptoms and dealing with seizure activity. So just to kind of note, as far as the recovery position for a seizure, and I know that you all have reviewed the recovery position when talking in emergency care. So again, really important while the person is having a seizure not to try to restrict them at all, and that gets talked about in the kind of treatment when you're sort of experiencing someone going through a seizure. Once they could then be moved into the recovery position, just to make sure that their mouth, their airway kind of stays open, because many times they will produce a lot of saliva. So just to kind of keep the airway open, this just kind of illustrates that recovery position. Okay, vertigo. Vertigo is a sensation of instability, loss of equilibrium or rotation. Many times individuals with vertigo, they kind of explain their experience like the room is spinning. Many times this can happen as a result due to some type of problem with the brain or spinal cord. It could also occur, so that's central vertigo. Peripheral vertigo could also happen due to problems in the inner ear. Okay, so there's inner ear issues that can develop as well that can cause this sensation as well. So the issue with vertigo becomes, one, recognizing that what the person is experiencing is vertigo. The next thing to look at is what's the cause of it. So it's important to note that the condition exists, but you have to find out why to make sure that it's not a, for instance, significant brain or spinal cord abnormality, and then kind of how to treat it. Some individuals may chronically experience this due to, again, inner ear problems and problems with the semicircular canals. And we're going to talk a little bit about ear function in the future chapters, but just note that could be one of your causes of vertigo. Multiple sclerosis. So this is another demyelination disease. So like Guillain-Barré, it has a little bit of a different pathological process. So it's a neurodegenerative problem. It's a lifelong chronic disease. So it is a progressive disorder that if someone develops, they basically get treatment for it to manage it, but it's not something that can be cured. So what happens here is you end up developing plaques in the myelin sheath. Okay, so again, remember going back to our discussion about the neuron and the myelin sheath surrounding our axons. Again, that myelin sheath is important for helping to transmit the nerve impulse at a faster speed. So that's what basically makes the myelin important for those nerves that require fast transmission. That myelin provides that. Here you get focal plaques developing and demyelination. The peripheral nerves are not affected. So all of the things that happen with multiple sclerosis, it's related more to the central nervous system. It is not a thing that affects the actual peripheral nerves. Most of the evidence does point to this, like Guillain-Barré, also being a autoimmune disorder. So again, the immune system is basically attacking the body itself and causing these sclerotic plaques to basically be formed on the myelin sheath. Amyotrophic lateral sclerosis, or ALS, also known as Lou Gehrig's disease. This is another kind of progressive neurological disease, and what this does is it attacks the voluntary, the neurons responsible for voluntary muscle actions. Okay, so again, another progressive disease. Both upper and lower neurons do get affected, and what eventually happens is those neurons will eventually degenerate and die. So again, it's another progressive disorder. So you have some, again, what I always tell you, so this is just kind of like a side note, again, when you're looking at your disorders, if there are disorders that are caused by common pathological processes and or what they affect, look at those together and just, still note the subtle differences, but it'll kind of help you remember some things about the conditions. So that was just a sidebar note. Again, so this will lead to complete loss of all voluntary muscular movement. The one thing to note is it does not affect your senses or cognition. So cognition and senses special senses do not get affected by amyotrophic lateral sclerosis. As the disease progresses, the muscular atrophy will spread, so basically the person's muscles will just atrophy and shrink over time. But as far as memory or personality, like they still they still have all of that. They don't lose it. But eventually what happens over time is they lose the ability to speak, because again, that's going to be a voluntary function. And over time, just other complications will develop with this. So these just kind of show some signs and symptoms of upper versus lower neurological disorder. So some of the things we talk about, this is present in your book. So this just kind of differentiates. We had talked about upper versus lower motor neurons. This just kind of tells you as far as if there's an upper lesion or a lower lesion. So the upper motor neurons are the neurons between the brain and the spinal cord. Lower motor neurons is from the spinal cord out into the periphery. So, if you look at this, you could kind of see what happens as far as what happens if you have an upper versus a lower motor neuron lesion. Bell's palsy. So Bell's palsy is a disorder that affects one nerve. It affects the facial cranial nerve, and it results in either unilateral or bilateral facial weakness or paralysis. So this is a condition that so it's kind of unique. So it's very focal to that one nerve. So again, you should be looking at your cranial nerves and see what they control. So the facial nerve allows you to, or is the cranial nerve that allows you to make facial expressions. So what happens here, it's usually due to an immune reaction or an inflammatory response. So if the person has had a viral infection in recent time, there's, again, due to some type of issue with the immune system, this could cause an issue that results in weakness or paralysis of this nerve. And there's a picture on the next slide kind of showing you classically what the person with Bell's palsy will sort of look like once this happens. It's important to note it's obviously scary for the person because they can feel it, but it's usually something that does resolve. Some people do suffer some permanent changes to their facial expression, but for the most part, This usually does resolve on its own. There are some other complications that could happen as a result of this, and that would be important to note. But take a look at this and look at some of the differential diagnoses, because this is something that obviously would have to then get diagnosed by a physician, but just to make sure that there's not a more serious condition going on, being able to realize and differentiate that from those other conditions is important. So here's a picture of Bell's palsy. So when you look at this, this kind of just shows you what happens. So inability to wrinkle the brow, diminished ability to close the eye, inability to puff the cheeks, inability to smile or pucker. Those are kind of some of the classic things you would see in somebody who would have a presentation of Bell's palsy. Again, this with no other symptoms, you're pretty much dealing with a classic Bell's palsy, and the hope would just be over time that this resolves on its own. It's a pretty varied period of time. It's anywhere from 1 to 8 weeks it could take this condition to resolve. Okay, rabies is an infection of the CNS. It's a viral infection, and it's transmitted from the saliva of infected bats and other mammals. So it is transmitted through animal saliva. So many times people kind of are aware, like if they do happen to be bitten by an animal that may potentially have rabies, that they need to go and get treatment for that right away. One of the problems with this, where an individual could have issues, is that there's a very long incubation period. So that's the time when someone's infected but they're asymptomatic or don't have symptoms. And then usually there's a period when the infection then eventually enters the central nervous system, and then the symptoms develop. Once the symptoms kind of develop, it is very difficult to then treat, and death could come soon after that. So very important, obviously, if an individual were to be bitten by an animal in the wild, short of being able to capture the animal and make a definitive determination that they should be treated with kind of they should be treated with a prophylaxis to make sure that they do not develop rabies. Okay, complex regional pain syndrome is an overactivity of the sympathetic nervous system. So this can occur. This is kind of an interesting disorder. It's very difficult to treat. So, we could definitely see this in somebody, particularly in an athlete who's had a surgery on a limb and they've been immobilized for a period of time. This is part of the reason why we don't immobilize people if we really don't need to. Granted, there are some conditions and some surgeries that require immobilization of a joint or a limb, but the faster you could get them moving, the better off you are. So this is basically an overactivity of the sympathetic nervous system. So one of the common things, this could even happen after a minor injury. So and again, they're not quite sure why this happens. It is a neurological phenomenon that we know. There's two different types. Type 1 usually follows an injury where some soft tissue is damaged. Type 2 is a new term for when there's an actual documented injury to a nerve. So those are both kind of two classifications of this syndrome. Really important to note, so this could happen in somebody who maybe just even experienced something as minor as an ankle sprain, and all of a sudden they just, for whatever reason, develop this overactivity of their sympathetic nervous system. Really important when you look at this, like many of the other conditions. So if you have somebody with a, mild to moderate injury and they're having some very unusual signs and symptoms, and this gets highlighted in the discussion in your textbook on this, that making sure that appropriate referral and treatment for this, because this is something that if it gets very complicated to treat, the further someone gets into it. So it's really important to make sure that this doesn't get prolonged, that if you start to see some of the significant changes. So just as an example, one of the signs and symptoms of this is kind of pain disproportionate to the response of the injury. So either you have a very mild injury, or you have a situation where maybe all of a sudden someone's experiencing all this great amount of pain over a body part where there was recently a surgery done and maybe they had been getting treatment. That would be kind of one of your red flags, and they'll kind of describe the pain. So like if it's a severe burning pain that all of a sudden they've developed, or maybe they've just developed in response to what would be a minor injury that shouldn't be there, that would be something that you would definitely want to take forward to see. Because again, if this gets discovered early enough and gets treated, many of the longer term kind of chronic issues associated with it aren't really present. Whereas if by chance it were to be prolonged a little bit longer, you may not be able to get away from that. So those are the conditions. Again, see what you can look at as far as being able to look at your disorders. So for instance, some of the disorders are neuromuscular disorders. You have concussion, you have all your headaches. So be sure to look at all of the signs and symptoms of them when you're doing your case study. Make sure to thoroughly go through all of the conditions before you kind of proceed forward with the actual case study and coming up with your differential diagnoses. So again, go back, look over the conditions in the textbook, note some of your important signs and symptoms, and look at some of your differential diagnoses and treatments related to these conditions.